Welcome back to those who have been listening and viewing our Breakthrough podcast. Thank you so much for being with us again on this amazing day. And welcome to those that are just tuning in for the first time. We are our Breakthrough podcast, where we will give you the breakthrough map to go from breakdown to breakthrough, from pain to purpose, from your past to living your greatest story. And today we have a special edition where I believe that we can get some expert advice as we're looking for people that are going through challenges and setbacks and obstacles and barriers and really telling their story of how they navigated that challenge. But it's even amazing and even better to have someone online that has actually been on the other side of that, where he might have been able to help people that were going through some challenges. So we'd love to hear from our expert today. And I'm going to let him introduce himself because nobody does it better. So please tell the people who you are and what you do.
It's a pleasure to be here with you this evening, Vernay. I'm Dr. Barry Perlman, and as Vernay and I discussed before we started, we're going to call each other by first names from this point forward during the podcast.
Yes.
I'm a retired psychiatrist, and I had a wonderful career. And after I finished, I wrote a memoir, Rearview, and we'll talk about that later. But I think the way maybe to put a bit of my life into perspective, a famous philosopher, I think it was Kierkegaard, said we have to live our lives forward, but you can only understand them looking backward. And so
the rear view, I get it now.
So when I think about my life and how I ended up in psychiatry, I have to go way back. I have to go back to my childhood. I had a grandmother, and I didn't understand much of it at that point in my life, who suffered from serious mental illness, what today we would call intractable depression, in a period before there were modern psychiatric medications. So my grandmother was hospitalized a number of times. She, as I understood it, received electroconvulsive treatment, which helped her to a bit, but she remained chronically ill. And that had an impact certainly on my growing up, because my mother and her sister were always seemed to be away and required to be on call taking care of their mother. My grandmother had been widowed at a very, very young age. And when my grandfather died, my mother was 14 and had two younger sisters. They were left in kind of precarious financial situation. My grandfather had been an architect, so that was surprising, but he had made some investments in things that turned out to be pretty rotten. And so that was the beginning of the story. Okay. Growing up as I did, and I think it's not so unusual, my parents thought it would be very nice if their son became a doctor.
Oh, and my goodness, they put
that. Never heard that story before. So that was always certainly in the back of my head. And I think the reason they thought of it was multidimensional. I'm sure they were not unaware that doctors made good livings, but they were also aware that doctors were respected in their communities and spent their lives, for the most part, trying to help people and do good works. So you put it all together, and that, I think, led to it. Now, my mother, it's interesting, was one of the founders of an organization in New York called The Bridge. And I think her interest in that organization grew out of her mother's illness. The Bridge was an early organization that assisted patients being discharged from psychiatric hospitals. In those days, if you went into a hospital, you stayed for an extended period of time. So returning to your home and returning to your community really represented a significant transition. So my mother became involved with this organization. And as a side note, I'll say many, many years later, I was part of an organization, on the board of an organization called Mental Health News Education. We put out a couple of publications for people with mental health issues and people in the autism community. And another fellow joined the board. And it
Okay.
turned out he was the executive director of the bridge.
Oh,
So I told him about my mother,
oh my
and he listened
goodness.
quietly. And the next meeting we all had together, he had dug through their files from 40 years before, and he brought in minutes with my mother's name on it, which was very nice of him.
Oh my goodness.
And for the ladies in the audience, like Brene, who obviously is very industrious, the minutes from the 1950s said, Mrs. Samuel Perlman. I'm sure if my mother had been on that board in the 2000s, the Mrs. would have been gone, and it would have simply said her name, Eve Perlman.
Okay.
So that was a real change as women began to come into their own in our society. So I went off to
Wow.
medical school. It was during the Vietnam War. I was very happy to be accepted because it meant I wouldn't be drafted at that moment.
Okay.
And that was a big relief for sure.
Absolutely.
And it's interesting. Then the question becomes, because in medical school, you take your courses in surgery, internal medicine, obstetrics and gynecology, psychiatry, and so pediatrics and so on. Why
Okay. So you
psychiatry?
get like a broad view of the medical.
Exactly.
Okay.
You get a
Awesome.
taste of everything. And it was wonderful. I really pretty much liked it all. But psychiatry had a special place as I read the material about the field. Now, I'm going to again back up for a second because I think it's interesting for people who think about why did my doctor go into that specialty? Often it's intellectual, the material is interesting. Maybe they're thinking about earnings, but there's another aspect, and I'm just going to give you a taste of it.
Yeah. You wanted to help your family?
Well, that was in my case, but before I get to me, I will say at Yale Medical School, my teachers included an orthopedic surgeon who didn't have a leg. He used to hop into the shower after surgery, take his
Wow.
prosthetic leg off. We had a hematologist, a blood specialist, who had a
Right.
clotting defect. We had a neurologist with a foot drop.
I see where you're
And
going.
so, and we
Mhm.
had an ear, nose, and throat doctor who had a congenital malformation which left him without an ear. So it's often very personal. And I won't even say anything about those of us who went into psychiatry and whether we were a bit touched. I'll leave that
Right.
for you. I'll leave
I
that
see
for
what you mean.
your audience's own imaginations. But in any event, I had incredibly exciting professors in psychiatry. And it was at a time when psychiatry was making a giant leap forward. And many of the psychopharmacologic agents, the drugs which psychiatrists use, were just being pioneered at that point. This is the
Mm,
late 1960s. And so for the first time, people with serious illness like schizophrenia, we've all heard of that.
yeah. Yeah.
Some of the drugs that work for that, the antipsychotic medicines, were just coming to availability for clinicians. Lithium was just beginning to be brought forward for people with bipolar illness.
Wow.
Antidepressants were just starting to be used for people with serious depression. So it was a very, very exciting time
Yeah, the cutting
and
age you came in on.
cutting edge. And you know, what's interesting in a certain way, we've made some progress since then, but it's been much more incremental. That was the time of the big leaps. I think in a lot of parts of medicine, you get a big leap every 10 or 15 or 20 years, and then things change a little bit till the next big leap forward. And so it was nice to be there when these things were being pioneered by my professors. And it made for an exciting time. And that's, I think, how I came to go into psychiatry, a combination of personal history,
Yeah.
intellectual interest, and being inspired by some extraordinary professors.
Yes, they sound extraordinary.
And I think most of
Wow.
us, I mean, you're in the media, and I wouldn't be surprised if you ever had a story about what brought you to media and show business. in your own
Right.
history. Everyone has
Right.
to be inspired by something if they're lucky.
Yes, yes. So, oh my goodness. Well, first off, thank you for sharing that story and sharing from the very beginning and kind of giving us a scope of who you are, but where you come from, right? Because who you are is very much your parents and who raised you and how they raised you. And kudos to your family. I mean, you guys were doing meaningful work before it was popular, right? Like you say, I mean, at the time, these are big risks when you're thinking about integrating certain medicines into these conditions that maybe we didn't have names for. And so that is a big leap. You were taking leaps and bounds as you were coming into the field. So talk a little bit about once you have kind of engulfed yourself in the field, you're learning, you're researching, you're gathering so much even from these amazing mentors. I think before we even knew what mentorship was, you were mentored by the best.
You know, you've got that exactly right. The word
Yeah.
mentor really didn't come into popular usage till probably I was in my 50s.
Oh
But in
wow.
retrospect, you're absolutely right. Those people were my mentors.
Yes, amazing teachers. So talk about any of the challenges that you faced because you were taking on a lot, um, not really knowing where was it going to go, where these things were going to work, what type of treatment people were going to get, and then how did it affect you as on a personal level, being so close to it, knowing what your family was going through? Talk a little bit about how you felt going through the process of kind of learning and being, an expert in that field.
I think medical school and then postgraduate training in psychiatry are incredibly intense years. And I
Mm,
think the
can
reason
imagine.
there are so many doctor shows that people love to watch on television is that when you practice medicine, it's about people's health and well-being and often about life and death. And that's not being overly dramatic. So one of the big transitions going from entering medical school to emerging from residency at the other end of your training is adopting a new persona.
Okay.
You're a kid, you go to medical school, you're 22 years old, you finish college, you studied hard, you got into medical school, that's great, but you're not a doctor.
Right. And you're still
And
young. Yeah.
somehow you have to put on a white coat a year or so later, and
Mm,
you're seen differently. I remember a wonderful moment when I was at a supermarket near the medical school, and I guess maybe I was standing near the produce section, and someone asked me where the strawberries were. And obviously, I looked like someone in a white coat who worked in the grocery store near the produce section. But
yeah.
no, if he had looked at my pocket, I had my stethoscope.
Oh,
And so you begin by modeling based on the people who you watch and using and integrating your mistakes, because we all make mistakes. And you begin to deal with people in extremis in their lives, and you mature pretty quickly, hopefully. And you
right.
begin
Hopefully.
to, right, you begin to act and feel a little bit like a doctor. So if a nurse, when you're in the hospital, yells, "Doctor," you don't look around for somebody else. You realize they're talking to you. And
Wow.
that's a transition.
Yeah.
One of the early experiences I had just gotten married. It was between my third and fourth year of medical school.
Oh, did
Um,
you meet her in medical school?
no, no, no. I got
Oh,
introduced by a classmate. She's an
okay. I
artist.
love a good love story.
Yeah, no, it's a good love story, but it's to an artist, not to another doctor.
Oh, okay.
And so we were away. I had done my obstetrics and gynecology in London, which
Mhm.
was a lot of fun. And we came back to New Haven. And one of the first people I met when I was what they call a sub-intern. You're
Okay.
learning to transition from medical school to being an intern and a resident the year after. So you have a lot of responsibility, but really a lot of supervision.
Okay.
And there was a
That's
young,
good. Right.
you betcha, you betcha. There was a young fellow in the hospital, my age. He was a graduate student, if I recall, in mathematics. And he had gotten married the same week that my wife and I had the prior July. and he was dying.
Oh
And
no.
that was brutal. That's why I remember him more than other patients. You know, the
Right.
saying, there but for the grace of go I, there for the
Yeah.
grace of God go I. It really hit me between the eyes because it
Yeah.
could have been me. There was his wife. She had
Wow.
been a wife just as long as my wife had been a wife.
Mm.
I'm sure I tried to be consoling and so on, but the case is so vivid because you begin to think about uh, people's tribulations and that your role is not only to cure, but also to assist when you can't cure. So you go through
Mm.
your residency after that, as the next 4 years, internship and residency. And again, wonderful mentors, more about being a psychiatrist. And it was right around then that we had our first child. And it's interesting because my daughter, who's now a professor, had a lazy eye and she needed surgery. And I felt heartbroken by my little kid on a gurney having to go for strabismus surgery.
Yeah, that's scary.
And it was tough, but it's also the point when you realize what the difference is between sympathy and empathy. Because
Yes.
suddenly there I was working with the families of youngsters, because when schizophrenia presents itself, it's often in the late teens into the 20s.
Okay. I'm
And
glad you pointed that out because that is valuable information.
very important for people. Maybe we'll come back to that. And suddenly I had to tell people that their son or daughter might be suffering from a mental illness, would limit their horizon for the rest of their life. You know, we all have dreams for our kids. We want them to do purposeful things, be successful, have happy lives. And suddenly people are having to reframe it and understand that maybe a victory for their kid, instead of becoming a lawyer or a social worker or a psychologist or whatever, will be that they can live independently and
Mm.
go to an assisted job and hopefully not be hospitalized too often. So that's another part of the process, is learning learning to help people um, with what they're encountering when someone in their family has significant psychiatric illness.
Right.
After I finished my residency, I spent a number of years on the full-time faculty at Mount Sinai Medical School in New York before
Okay.
becoming the director of psychiatry at a community hospital just outside the city in Yonkers, St. Joseph's Hospital.
Wow. Okay.
So um, that was a very, very big transition because I went from hopes of being a researcher and so on, but I had to support a family, wanted to make somewhat of a better living. And also, as anyone who looks at my last name might guess, I'm Jewish. And suddenly I went to St. Joseph's Hospital, and my boss was Sister Mary Linehan. So
Oh,
that had not been in the cards when I was growing up, that my boss would be a nun, but it
wow.
started a great relation. She was my boss for the next 20 years as president of the hospital.
Oh, wow.
And I loved working for the Sisters of Charity of St. Vincent de Paul because they just were a group of religious with a big heart. Didn't mean they weren't tough. We still had to have a bottom line because the hospital
Right.
had to survive.
With
But
the ruler.
absolutely, the hospital had to survive. And I also learned I didn't need to know all the nuns' names. They just say to any doctor, "Good morning, doctor," and we could say, "Good morning, sister," and we could get
Okay.
away with that.
Right.
So, so that's where I was for the next 34 years until I retired. And what
Wow. So
and
you really loved it there. That was a family. You
it was a
probably spent
family.
a lot of
That
time
used
with
to
them
be
there.
our advertisement.
Mhm.
More than a job, a family. And we fought
Oh,
like family
wow.
too.
Yes, I would imagine.
So what I learned then was, for especially people with serious mental illness, severe depression, schizophrenia, bipolar illness,
Mhm.
maybe severe obsessive compulsive illness, was how the mental health system in the United States and the mental health insurers didn't treat those disorders equitably.
Talk
Now,
about that. Yeah, break that
okay,
down.
yeah, that's important. And I knew this a little bit because when my grandmother was hospitalized, I knew that the family had to shell out of pocket to pay for it because there was almost no health insurance that covered mental illness in the 50s.
Oh
So
my
we
goodness.
began to fight against the inequities in the health system for people with mental illness. And I will say, the way I thought of it in a certain way was as an extension of the civil rights movement, of which many of us had been a part, back in the 60s and so on. And what came of it, I got involved with organized psychiatry, and that was exciting because it was a way to help on an advocacy basis the people who I was treating and who my department was treating.
Okay,
So what am I
awesome.
talking about? During my career, I had the pleasure of being the president of the New York State Psychiatric Association and also the chairman of the New York State Mental Health Services Council. And by being involved with these groups, we started to do a few things. And maybe your audience will resonate with this. One is it's not easy to get people to go for mental health care because of
I
what's
know I can relate.
called stigma. You've heard the word stigma.
Mm-hmm.
Now, we've made a tremendous amount of progress. Psychiatry and all the other mental health professions have been fighting against stigma for the last several decades. So more people are willing to get treatment now than ever. But there are certain groups that still find it difficult to ask for care, especially groups like the armed services, the police, people who are often in very traumatic situations. They need care. We know about the suicide epidemic among veterans.
Yeah.
But they're afraid that if they seek mental health care, it may hamper their career advancement. And so a lot of work is going into that. So stigma was one part of the advocacy effort. Another incredibly important part was getting people, when they had health insurance, real coverage for their mental health care.
Yeah.
And the fight for that, and this
'Cause I
word
feel like
may or
there's
may not be,
limitations.
yeah, the word that was the kind of umbrella for that was getting parity.
Oh,
And
okay.
okay, and now that became a nationwide fight. In 2006, right at the end of his time as governor, Governor Pataki in New York signed Timothy's Law, which was the New York State Parity Bill. And that extended equality to mental health care under certain conditions. 2 years later, 3 years later, 2 years later, the end of 2008, I guess it was, President George Bush signed a bill which included the Mental Health Parity and Addiction Equity Act. And what that did was, when you put the two of them together, and many other states also passed parity laws, they said that people who have health insurance, and again, it's complicated, but have to get treated equally for their mental health care as for their physical health care,
Right.
in both quantitative and non-quantitative ways. So quantitative would mean you can't have limits on mental health visits if you don't have limits on physical health visits. And non-quantitative was somewhat different. Now, what has been dismaying and disheartening is that was passed in 2008. It's now 2022,
Yeah.
and we are still fighting battles tooth and nail with the insurance company. The
Yeah.
litigation has never stopped because they have not honored in spirit or in detail those laws. And in fact, there's a bill being drafted in the Congress now, which would penalize insurance companies if they don't properly comply with the Mental Health Parity and Addiction Act. Up till now, in a certain way, it was easy for the insurers to deny care. If you were going to be hospitalized, they didn't bear any liability if they said, we don't think that person needs to be hospitalized, and the ER psychiatrist thought they did. So if the patient were discharged because they weren't going to be covered and something happened, it was the psychiatrist who would be sued.
Right.
And if the patient came in when they said, we don't think they need to be hospitalized, then there'd be no coverage without an appeal. And appeals are time consuming, they're costly. And the
Exhausting.
worst that happens for the insurer, if the patient comes in and they lose the appeal and they have to pay, they just pay what they should have paid in the first place.
In the first place, right. And that would have
So
been
there's
easier.
no penalty.
Right.
So part of what advocates for persons with severe mental illness and for mental health parity are fighting for right now is to penalize companies when they don't do what's right and they don't adhere to a law now 14 years out from when it was passed.
Okay, so can I ask you something?
Sure.
And it's so funny, you know, I want to say doctor, because you know how I usually address
But you're
you,
just going to say Barry.
If I could ask you something, Barry. So I love everything that you're telling, and you're giving us a lot of information, of course, the history of it, right? Where we started, what progress we've made, and to a degree where we've kind of remained stagnant. Because like you say, we see the pandemic, we see the epidemic of, like you say, suicide, the rise in mental health, the remnants and the byproducts of not acknowledging mental health. We've seen where that's gotten us and as a country and as a nation. So I don't want a lot of what you're talking about to go over people's heads. I do want to speak a little bit more on layman's terms, in terms of what you've seen, and when people are going through a really rough time, what can they detect? If you're able to take liberty in kind of speaking to some of this, just in your experience, right? You don't even have to speak as doctor, right? Because like we know, you are retired, but what would you say people should be looking out for in terms of, okay, saying, something's not right. Maybe I haven't been feeling well. Maybe this has kind of been lingering. Perhaps I should go and speak to somebody, because I'm sure you've seen a lot. And I'm sure you, being an empath, right? When we talk about, and I'm an empath, being an empath, like you say, the difference between sympathy and just empathy, being an empath, you tend to internalize and take on those things. I'm sure by you seeing a lot and treating and speaking to families, I'm sure it takes a toll on you as well. So when do you suggest that people say, maybe I need to talk to somebody, maybe I need to pay attention to this, maybe I need to make note of these patterns? What can you lend to those that are listening that may be just going through some struggles, and they may be circumstantial? What can you give them in terms of advice?
Let's do it in two parts, because I think you hit on two things.
Okay.
One is, what's the impact on the provider, on the doctor? Actually,
Yes.
I hate the word provider because I did not graduate from provider school. That wasn't
Right.
the graduation my folks came to.
Okay,
They
that
came
makes
to
sense.
medical. But I think it does take a toll. And I think it's a rare person, whatever your field is, who leaves it all at the door when they go home at night. So for psychiatry, just to take one example, there's probably very few psychiatrists who work with severely mentally ill people who hasn't had a patient take their own life. And that's just brutal.
Oof,
for the
that is
doctor
brutal.
and for the
I felt
social
that.
workers and the psychologists and the whole staff. You've done your darndest to try to understand it. You've done your darndest to treat the person. You try to be available. You make the best and most careful evaluation you can.
Yeah.
But sometimes you get it wrong. And sometimes it surprises you. And when that happens, then I think many of the professionals, myself included, would question themselves and whether you were competent and you weren't. So there are struggles to being in the field and being the ones who are providing treatment and caretaking.
Okay.
So now let's move it to the other half of your question, or
Yes.
maybe the other 2/3, the bigger part. When should people consider looking for help,
Yes.
looking for assistance, and how do you go about it? The number of disorders is huge. So we'll take them in just a couple of brief groups and try to do it quickly. We said earlier that schizophrenia often comes on in the late teens, 20s, begins to taper off in terms of new cases into the 30s. But if parents begin to see radical changes in their children or teenagers or young adult children's behavior and function, those breaks in continuity of that individual's usual way of being is something that at least deserves consideration.
Okay.
If you are married, for example, I assume many of your audience are married or have significant others of one sort or another. And again, someone starts to mope around who used to be upbeat. They're not doing well on their job. Maybe they're coming home and saying, the boss is angry at me. They're not sleeping well. Their appetite is diminished. We're looking at change. Then maybe that person is experiencing a significant depression.
Okay.
Maybe their concentration is diminished. They're not enjoying the things they used to enjoy. You told me before we started this evening, you were a singer. I assume you love to sing.
Yeah.
Suddenly, your friends said, you know, Vernae, she doesn't sing anymore. That joy.
My mother said that to me recently. I'm like,
oh
no.
no.
Mommy. Yeah, it has changed. I tell you, I have gone through a life change. We'll have to do part 2 where you can advise me.
Okay.
I can be on the couch for a minute.
Well, I had no couch, but we'll go into a conversation.
The virtual couch.
Actually. So that's another time to say, could there be a depression going on? Yeah. Sometimes suddenly in their 20s or in their 40s, someone begins to have big mood swings.
Okay.
And they don't need sleep. I had one lady who every year, just as the days were getting longer, she was a bipolar patient. She'd begin to be up all night. She'd be cleaning the house and vacuuming in the middle of the night. She was someone who had never cared much about intimacy with her husband. But when this hit every year, suddenly she was attacking her husband and wanting a lot more intimacy. So that was a change. She was getting bipolar. She was getting manic.
Interesting. Okay.
So we're looking for changes from our own unique and individual baselines. Maybe a member of your audience is married to a policeman or a soldier, and suddenly that person is frightened, down, drinking more, not wanting to drive past certain places, being avoidant. Maybe they're beginning to experience post-traumatic stress disorder.
Yes, I was just about to say the trauma.
So I think the thread that goes through all of this is when you know people well and you notice significant changes in their patterns of living that you're accustomed to, don't just shrug your shoulders. Have a conversation with them. Suggest they talk to their primary doctor, or suggest they go to a mental health professional for an evaluation. But I think the main thing is when you notice important change in people you care about, deal with it. Don't let it just slide and say, it'll get better.
Right.
An interesting example, because we've all experienced losses. People have died in our lives, parents, friends, whatever. Most of us get over it in 3 or 4 months, not in the sense that we never think about them, not in the sense that we don't miss them or care about them, but even though we may be very, very hard hit immediately when they pass, and we're not sleeping well, and we're not eating well, and we're not concentrating, over the next few months, generally with good support systems, friends, family, we kind of begin to get back into our old routine. So if at 3 months, 4 months, 5 months, someone is still almost seeming as though the loss just still happened yesterday, that would be time to say, well, maybe there's pathological mourning. Maybe the depression connected with loss is lasting longer than it usually would. We use the phrase biological rhythms. We all
Yeah.
have certain sleep patterns, appetite patterns, enjoyment, those kind of things. And generally, those biological rhythms start to restore themselves after a while. And if that's not happening, that's
Yeah.
another reason to seek consultation.
Oh my goodness. Well, thank you so much for saying that, Barry. I mean, you said a lot, and I do want to just take a moment to reiterate it for those that are really taking notes, or even just taking inventory of the people that are in their lives, or even inventory of how they're feeling right now. I love that you talked about the continuity, right? The continuity in behavior, the continuity in a rhythm, a daily rhythm, whether it be your kids, whether it be yourself, your loved ones. I also really love that you introduced to the conversation the idea of grief and loss. That was one of the reasons why I created our Breakthrough podcast. You know, this idea of breaking through, and the idea of our society really not being able to, deal with grief and loss, and really kind of open the discussion in a way where, like we just said earlier, where there is no stigma attached to, okay, wait a minute, I know that I should feel like I'm over this. People might believe that I should be over this, but I'm not really getting over the hump. Maybe I haven't gotten back to my old routines. And as you mentioned, maybe I'm not feeling, as inspired or finding the joy in things that I once enjoyed. So all of those things are really something to think about, something to notice, and I appreciate that you mentioned that. So before we wrap up, I do want people to know exactly where you may be able to direct them to some resources. Because again, you're retired. We want you to continue retiring and enjoying your life. Maybe do some travel, read a good book, right? Because you worked really, really hard. As you just mentioned, and kind of took us through the history of what you've been through in your profession. Can you tell people, of course, about your book that we mentioned earlier, and then, of course, how you can maybe better direct them to some resources and some help?
So let me start off with the resources. We just went through kind of a quick overview of some of the reasons someone might seek mental health care. And obviously, where you go depends on who you are, your circumstances, whether you have insurance, don't have insurance, what your community has. But good resources, often there's to start with a primary care doctor, a family physician.
Yeah.
Many communities, as the one I worked in, had community mental health centers or hospitals with psychiatric divisions, which could be called. And many of those, for people with limited resources, charge on sliding scales so that people can afford to access care. Now, I have to say, and it's too bad, but anyone who reads the newspapers knows what I'm about to say next. It's tough getting access to care these days, not because of the lack of observance of the parity law and so on, but because during the 2 years we've been locked down with COVID, the demand for mental health services has just skyrocketed. People are
Yeah.
feeling isolated, lonely, alienated, depressed, drinking more. You just think it all.
Yeah.
And so if you need it, seek it and keep pushing for it, because you will get there, but it takes a little bit longer and the line may be a bit longer
Yeah.
than it
A
was
little bit more
before
perseverance and
COVID.
grit.
Right.
Yeah.
So I think that's the way to go about it, but don't take no for an answer.
Awesome.
Now, I really appreciate being on the podcast, because one of the things that would make me happiest if those who are listening would consider purchasing a copy of my memoir, my book. It's called Rearview:
Yeah.
A Psychiatrist Reflects on Practice and Advocacy. You
Okay.
can
You can
go to,
hold it up for those that are
oh,
viewing if you have
okay.
it.
Whoop,
Uh,
I didn't know this was
Can
viewed.
we, can we get it in the frame? Okay.
I'm not sure.
Oh, and that's okay. And if we
I,
can't, I will make sure
I
that
sent you
link.
a cover.
Yep, and we'll make sure that link and the information will appear under the interview. So
Okay, I
it's
didn't know
okay. We'll
that we were
definitely.
being photographed. I just knew that we were doing a podcast, so I would have used a
Yes,
different format. I'm
some people
sorry.
view it and some people listen to it.
Okay. Anyway, please think of buying a copy on Amazon. My name is Barry Perlman, And you have to spell it Perlman. If you type in Barry Perlman Rearview on Amazon, it'll pop up. And I think you'll find it interesting, both in terms of the cases that I describe of people I've worked with, the advocacy efforts, which go well beyond the parity and stigma issues that we talked about, into interesting areas, including transplantation and so on. It tells more of my personal story. And so you would do me an honor if you would consider purchasing a copy. It's
Absolutely.
excessively inexpensive on Amazon right now.
Yes.
Keep marking me
Absolutely.
down.
Absolutely. Okay. And do you have hard copy and digital, or is it just hard copy?
There is digital, there's an ebook or an
Okay.
ebook, and there is a paperback.
All right. Well, you've got it here. You heard it here, guys.
Terrific.
That there's definitely easy way that you can get access to information, access to your very rich story and history within our medical field and the profession, and just the life that you built for yourself. And we thank you for your service. We thank you for your level of advocacy. We thank you for educating our audience today on everything that you've been through, and giving them some of those pinpoints and bullet points to really look out for and to think about. And yes, I will make sure that all your information regarding the book will appear on all of our streaming platforms. I appreciate you guys for really listening in today. For those that have been staying locked into our Breakthrough podcast, we appreciate your support. Make sure that you are liking, commenting, rating, and subscribing across all streaming platforms, our Breakthrough podcast. And we just want you to remember that this is the place where we are going to give you the breakthrough map to go from breakdown to breakthrough, from pain to purpose, from your past to living your greatest story. You stay locked in, and thank you so much for being with us. And until next time, keep breaking through. Bye.